minutes in. Like, so you can join when you start coming in. True or false? Crypt cells produce and store. Oh, all right. So definitely there are some studies to do. Not crypt cells, okay? Crypt cells are those like, pumping fluids, right? Enterochromaffin enterochromaffin cell. Yep, EC cell or enterochromaffin cells. So that's the correct cells. So notice this cell type, okay, when you're studying. So you can only select one. So pick either one of the two that is correct. That's fine. Right? Yeah, acetylcholine and substance P's, not the other two, not the other two. Nitric oxide is a relaxation, right? Relaxation. Contractions, relaxations, notice those little difference there. Stone, one of those lipoprostone, lipoprostone. All right. So here is the trick here. Now you know it's about chloride. It's affecting chloride ion. I expect you after you study, notice which one of those chloride channel, right? And then how does it involve in its pharmacological action? So you activate it, what's happened, right? The effect of it, right? And then link it to indications, link it back to Dr. Hall's material, right? When is it used? So they all should be all in a continuous flow in your mind. All right. In the Clotai. Yep, that's true. So notice that the other two, including linaclotide, its action is on the guanylate cyclase C. Okay, it's that, and then through secondary messenger, and then activating the chloride channel. So notice that detail there. But densitron inhibits. All right. Now, so here it's not testing you particularly the subtype of the receptor, but more so if you know it is an antagonist or agonist, right? I'm gonna say it one more time. Hopefully you will remember. They are antagonist, all right? If you remember Megatron, the antagonist of the story, okay? I don't know if that helps. Hopefully you can draw some association, make you know, remember a little bit easier. All right. So this statement has a lot of things to involve. Activations of D2 receptor can reduce nausea and vomiting. Is it true or not? Okay. Now, so this is an example. This statement seems very straightforward. You know, it's not a whole lot of there's a involvement of a receptor, there's a pharmacological actions, activations, and then there's a pharmacological effect. Is it reduce or nausea? Is it reduce or increase, right? So that is something you need to get clear in your head when you're preparing for my content in the exams. You got it. I bet some of you during exam is going to be debating yourself. Is it inhibition or is it increase or decrease or is it activation? Now I'm going to say it right now. It's going to happen if you don't prepare well, if you don't get clear on those head. Now, there are ways to approach it. First, you need to remember those nausea and vomiting drugs, except those cannabinoid that we talked about, endocannabinoid system. Everything is an antagonist, right? Everything is an antagonist. What is the effect of antagonist? They're inhibiting these receptor. So if you see, and then the next thing is, what are those receptors? What are the neurotransmitters involved in nausea and vomiting? Um, D2 receptors are those one of those. So the the moment you see activating receptors other than like cannabinoid, that saying is reduce nausea and vomiting, that is not true. That is not true. It should be antagonizing these receptors. Okay, they're all antagonists. So keep that in mind. And I just want to say you're going to see statements like that on exam. Well, not exact statement, but the variations of that type of a statement. All right. Again, very similar activation of dopamine receptors in the intestine reduce GI motility. Again, so probably half of you are just guessing at this point. So that has to do with how the opioid receptors, dopamine receptors, and all those interact with acetylcholine release. Like so notice that that dopamine release binding to D2 receptors on that acetylcholine releasing neurons are going to reduce um, acetylcholine release, and that's going to reduce GI motility. So again, that is all interplayed, all right, all interplay, and those are pharmacology thinking questions. Metoclopramide. Yep, there are multiple answers. Just the metoclopramide, there's antagonizing different receptors. Okay. Also notice that it has central peripheral effect and all these. All right, so I have a questions about uh does that mean that constipation effect is linked to reduced nausea and vomiting? Um, so nausea and vomiting, okay, there are peripheral and also central effect, all right? So if you have the nausea and vomiting is first of all, there is an activation of those chemo trigger zone in the CNS, right? And activating not just dopamine, right, but also serotonin, which is one of those bigger role that is causing nausea and vomiting. Now, if you antagonize central D2, you achieve some goals in terms of reducing nausea and vomiting. But at the same time, if you antagonize peripheral, okay, now remember, activating those will have reduced constipation, reduce peristalsis. But you antagonize peripheral, you will promote peristalsis. Now, the effect between peripheral and central is a little bit more complicated. So I want you to be able to distinguish it separately. Don't necessarily tie it all together. Now, there are going to have some uh, uh, crossover effect, but just to make that clear, I don't know if I answered your question, Kingsley. Does that mean constipation effect is linked to? It's not necessarily linked one to each other, right? Okay, so that's, it doesn't link, but there is this effect that is happening when you're antagonizing either central or either peripheral or both. And what it's shown is that if you have peristalsis, things are moving down, you're going to reduce nausea and vomiting. But you have just constipation from other means, you don't necessarily have nausea and vomiting. So I think that would answer your question, probably. All right. Yeah. So this is a question related to CB1 receptors. Yes, so it can reduce. Okay, so that is really the take-home message. Among of other things there. It if for the ease of it, they are not autoreceptor, but you can think of it as almost like an autoreceptor type of effect. But autoreceptor is very specific, right? Like epinephrine binding back to alpha two, things like that nature. But here is we have a like a universal system like CB1. It's on a lot of different presynaptic neurons that is releasing different types of neurotransmitters. So make that have that clear in your mind. All right, one last one. Does it show the picture? All right, so serotonin is the one with the white background. The other molecules there, sorry, it's not white in background. Um, like so the answer is true. It could be. Oh, it's not showing at all. But the idea is if you can um, recognizing some similarity between uh, serotonin and serotonin antagonist. I'm not going to throw in a mix of molecules that is not shown in lecture slides. So I've also on lecture slides I've also circled out some similarity for you to look at. So that is what I expect. You don't necessarily to know what that drug is, but more also of recognizing certain features on molecules, and you will have some reference molecule to go with. It's not going to be very, very crazy. So it's something very similar to what you see in the last exam where there's a molecule spawning some similarity, okay, along that line. So we have IBS, okay, being the first one. All right, so my screen. Congratulations. They're gonna walk that island. No, didn't this time they didn't walk that island thing.
We want the island back.
Oh, there's an island too. Oh, about half of that is correct overall. Math. We're not gonna do any math in my thing, okay? Don't worry. Yeah, you've reached island level 2. All right, okay. Let me let go of this. Stop share. All right. Questions, like I said, if you have other questions pop up in your head over the weekend, email me. I'll try to respond as quick as possible. Okay. Um, that's my part. I'll hand the time to Dr. Hong.
All right, thank you, Dr. Hong. I also have a Kahoot prepared. So sign in. There will be a prize associated with the winner of this one. While you're signing in, you should be reviewing the case quizzes that we did this block. A lot of the questions on my part are not remember. They are related to this is what's happening with the patient. What's the best choice based on the patient specific items? So similar to the cases, but a much smaller case per se, a 1 or 2 sentence case. So most of my questions are apply. So you have to know how to use the drugs based on their indication and their side effect profile and who they can be used in. So most of my questions are apply. All right, I think 15 players is about what Dr. Hong had. So even though there's 28 of y'all in here. We will get started. The sooner you get signed in, the sooner you can work to earn that prize. You know it's going to be great, like a Bristol stool scale for your bathroom. Jessica is not amused. She's like, I do not need that decor in my bathroom.
Just so you know, I've seen adult versions of it. Maybe Jessica, you would like that one.
Which is a risk factor for acute and chronic pancreatitis, gallstones, genetic mutations, alcohol. All right. So For acute and chronic, the biggest risk factor is alcohol, as it relates to pancreatitis. All right. Gallstones are more acute because they're causing an obstruction, and that's going to hurt right away. And so you're going to get the gallstones out, or your gallbladder removed, and that gallstone issue should mostly go away. Genetic mutations, like alpha-1 antitrypsin deficiency, it leads to chronic pancreatitis. But alcohol, like binge drinking alcohol, so going out and partying for your bachelor party or your bachelorette party all weekend and giving yourself pancreatitis or rhabdo can happen. But also chronic alcohol use because of the toxins can lead to chronic pancreatitis. All right. Which is not an indication for stress ulcer prophylaxis? Elevated INR, low platelets, mechanical ventilation greater than 48 hours, hospital admission. All right. So, just because you're admitted to the hospital doesn't mean that you get stress ulcer prophylaxis. All right. I did not get stress ulcer prophylaxis when I was admitted to get my gallbladder out because I was on a general surgery floor. So it's an ICU, so intensive care admission. It's if you're ventilated for greater than 48 hours or you have coagulopathy. So that it would be an INR greater than what?
1.5.
1.5. Not on warfarin or any drugs that can affect the INR, and platelets less than
50,000.
50,000. Great. Yes. All right. So you have to be in the ICU, critically ill, and either ventilated, so the tube is down your throat, not oxygen, for greater than 48 hours, or you have coagulopathy. Those are the people who need stress ulcer prophylaxis. So is Jessica or Jesse? Or don't we want to say until the end? Jesse? Okay. All right, so this is just reiterating what we just talked about. They have to be critically ill and one of the following. What questions do you have on stress ulcer? Who needs stress ulcer prophylaxis? All right, so when the patient comes out of the ICU, we can stop that stress ulcer prophylaxis if they don't have another indication for a PPI or H2 receptor antagonist. Again, PPIs are one of the biggest interventions you can have as pharmacists. Okay, which is a symptom of acute pancreatitis? Weight loss, diabetes, abdominal pain, steatorrhea. All right, almost everyone got that correct. So when we have acute pancreatitis, what are the signs and symptoms of acute pancreatitis besides abdominal pain?
Nausea and vomiting.
Yeah, nausea and vomiting and abdominal pain are the signs and symptoms. All right. And it comes on fast, acute, it's very fast, it's very sudden. Chronic pancreatitis, on the other hand, is something that happens over a long period of time. And we typically start off with that steatorrhea, which means we're not absorbing fat that we're eating and nutrients that we're eating. If we're not absorbing what we're eating, that can lead to weight loss, right? And it can also lead to osteoporosis because we're not absorbing fat soluble vitamins like vitamin D, and vitamin D is important for calcium absorption and bone. So everything starts for chronic pancreatitis with steatorrhea and kind of goes from there to weight loss. And then diabetes is end stage chronic pancreatitis. Remember that the exocrine function is the endocrine function is the last to go when the pancreas is dying, right? So diabetes is stage 4 burnout, but that's a chronic pancreatitis issue. Better watch out. IBS is the highest climber and they won the last time, so they're coming for you at the top. Which lab value is most specific to acute pancreatitis? All right, most of you chose the correct answer. What is the issue with amylase?
It's not specific.
So it's not specific to the pancreas. There are other reasons that the amylase can be elevated. The other reason we don't measure it because it has a very short half-life. All right. What is AST and ALT specific to?
Liver
injury.
Yeah, liver injury. And what about bilirubin? What is bilirubin specific to?
Cholestasis.
It could be related to cholestasis, but it can also be related to cirrhosis overall and liver injury. So don't forget what you learned last exam. So pancreatitis, remember that they have to have abdominal pain. They have to have, for diagnosis, abdominal pain, imaging, and a lipase 3 times the upper limit of normal, right? They have to have 2 of the 3 of those. Ooh, Nesty took to the top. Right, which medication is used to treat ulcers? Cimetidine, sucralfate, pantoprazole, misoprostol. Oh, this hurts my heart a little bit considering what the bonus question was on the cases that we went through yesterday. Oh. Okay. So I'm glad nobody picked cimetidine. What type of drug is cimetidine? I know we didn't talk about it much this block, but we did talk about it in self-care, and so I do expect you to remember it.
HDRA.
Yeah, so it's a H2 receptor antagonist, so histamine 2 receptor antagonist. Does not elevate the pH, right? It has a short half-life. It does not last the full 20 hours. It does not elevate the pH of the stomach, so it does not provide that stability that is needed for healing, right? Because we need to decrease the acid to promote the mucosal healing so that we don't have a bleed, all right? Sucralfate, what did I say sucralfate was like yesterday?
The GI protectant.
The
Or,
Band-Aid.
wait, no, sorry, that's misoprostol.
Yeah. So yeah, sucralfate is the Band-Aid. We're taking this slurry or chewing up this tablet right before we eat so that we can eat food without it hurting. So sucralfate is just for symptom management. Okay. And then, like Jesse said, misoprostol is the preventative. That is what we're going to use to prevent NSAID-induced ulcer. So it doesn't treat, it's for prevention. So that leaves us with pantoprazole, which is what type of drug?
PPI.
Right.
PPI. I'm glad you all said PPI and not antifungal. That azole could be a little confusing, right? If we're only remembering the suffixes and prefixes of drug types. So pantoprazole is a PPI. PPIs, are slower to work. It takes 3 to 5 days for them to start working because, as Dr. Hong explained last semester, They have to be absorbed into the bloodstream. They have to go to the liver to be activated. They have to go back to the stomach and turn off the pumps that are active. But they irreversibly bind to the proton pumps. So the only way to overcome a PPI is to produce more proton pumps. Okay, so proton pumps are much more potent, do a better job of increasing that stomach pH, stabilizing the ulcer, stabilizing the bleed, and allowing it to heal. Which treatment of acute pancreatitis decreases morbidity and mortality? Albumin, ondansetron, lactated ringers, morphine. Right, excellent. So decreasing morbidity and mortality, remember that patients who have acute pancreatitis are dehydrated, not only because they have nausea and vomiting, but because of the inflammation process that is going on inside of their body. So crystalloids are the most important thing that we can do to prevent the patient from having necrosis, organ death, and overall morbidity. So crystalloids are things like normal saline, D5W, and lactated ringers. Lactated ringers has been shown to be more beneficial than normal saline when in patients with pancreatitis. So lactated ringers is the correct choice. Nobody chose albumin, thank goodness. Albumin has a short half-life as a colloid, so not super useful. Ondansetron, I would imagine you were all thinking that it prevents the nausea and vomiting and helps maintain fluid, but when the patients come in, they are already dehydrated. They are already have not enough fluid. So we really need to tank their fluid up so that they are able to perfuse their organs. And morphine is for the treatment of pain. So ondansetron and morphine are important for symptom management, but they don't help with morbidity and mortality. Okay, which patient should receive famotidine for stress ulcer prophylaxis? 48-year-old in ICU with INR 1.9, not on anticoag. 80-year-old in ICU on ventilator times 72 hours. 52-year-old on gen med floor, status post knee replacement. 60-year-old on gen med floor with INR 2.6 on warfarin. Ooh, okay. Jesse's doing a celebratory dance there. All right. So we have to think of this asking this drug famotidine. So we have to think about issues with the drug famotidine. So what issues are there with famotidine?
It's a H2RA medicine, and it's more like used in caution in elderly and with renal impairment.
Yeah. So famotidine, we have to worry about the cognitive impairment that can occur, especially with patients who have renal impairment or who are elderly. So we would not use this in the 80-year-old because 80-year-olds are advanced adult age, right? So that would be dangerous to use in this patient because it could increase their delirium, it could increase their confusion, and so it could be hard to get them off the ventilator by adding another medicine that can contribute to confusion and sedation. All right. So that one is out, even though this patient does need stress ulcer prophylaxis. The 80-year-old on the ventilator for 72 hours definitely does need stress ulcer prophylaxis, but a proton pump would be better in this case because they're elderly and at risk of side effects from the H2. The 60-year-old on the gen med floor, so it's a gen med floor, it's not the ICU, and their INR is elevated because they're on warfarin. Warfarin increases the INR, so this patient, there's no indication that they're under any kind of, they're critically ill. The 52-year-old is on a gen med floor and their status post knee replacement. There's no indication that they're intubated. There's no indication that their INR is elevated. They're on a gen med floor. Knee replacement is usually pretty benign surgery as far as risk. The recovery is probably a little more tough. All right, so that leaves us with the 48-year-old in the ICU. The INR is 1.9. It's a greater than that 1.5 threshold that we talked about earlier, and they're not on anti-coag. So the reason that their INR is elevated is because their liver is going kaput because they're critically ill. Okay. What questions do you have on this?
Is this session being recorded?
We are not recording this session.
Okay.
But this is very similar to a question you had on the cases yesterday, and there is a rationale there for that. So that should help you. Right. Which medication is most likely to cause drug-induced pancreatitis? Acetaminophen, diltiazem, metronidazole, colchicine. Ooh, okay. So acetaminophen is likely to cause which type of drug-induced disease?
Liver.
Liver. All right. Diltiazem. What's the issue with diltiazem?
Causes constipation.
Yes. So it's a calcium channel blocker. We talked about yesterday. Calcium causing constipation, as in when we talked about last semester with our antacids, calcium antacids causing constipation. So that's how you can kind of tie all that together. Remembering diltiazem is the calcium channel blocker. Calcium is related to constipation. Right. What does colchicine cause?
Diarrhea.
Diarrhea. Yes. Thank you, Shirley. And so metronidazole, how does metronidazole cause drug-induced acute pancreatitis?
Accumulation of toxins.
Yeah, so free radicals, toxins. Is that going to show up on an ultrasound, on imaging?
No.
Yeah, that's a good guess, Jesse. No, there's no way to tell that that's what's happening. There's no lab value that we can get. So there's no hypertriglyceridemia. There's no hypercalcemia. There's nothing on the imaging showing that there's an obstruction because these are toxins. It's something that we think is going on. Theoretical, there's really no way to test for this. Okay, if you were listening, you should get this answer. How does metronidazole cause acute pancreatitis? Gallstones, angioedema, hypercalcemia, toxins. So how many people were listening? All right, so toxins again are the way how metronidazole, there's always one. But toxins are how metronidazole cause pancreatitis. Not going to show up on imaging. What diet should be ordered for patients with acute pancreatitis upon admission to hospital? NPO, nothing by mouth, clear liquids, full diet. Ooh, okay. Why do we want them to have access to a full diet as soon as possible?
To decrease the length of stay in the hospital. This was a trick question. I think, even though I did choose that.
Why do you think it was a trick question?
Because it was like, we want them to eat, but they're being admitted in the hospital for like this pancreatitis. So it's not like they're gonna want to eat, but we need to keep them on a diet so it decreases the length of stay in the hospital. And yeah.
Okay. So, yeah, so I don't believe in trick questions, Jessica, despite what Jeff said yesterday when he was giving the conversation, but it does cause you to think, right? Because it's counterintuitive. The patient's coming in with nausea and vomiting, so why would they want to eat? But there's no reason for us to withhold eating from them. So we want them to, if they don't have an order for a diet to eat, then they can't eat, even when they start feeling better. So we want them to have that diet in place. So as soon as they start feeling better, they can eat, and that helps them get out of the hospital faster, helps decrease necrosis and things like that. So I think it's tricky to think about and understand what happens in the hospital and what you need in the hospital. Do I think it's a trick question? No, but it is tricky to wrap your head around that if you haven't worked in a hospital. Ernesto, did you have something else to add?
Yeah, I had the same rationale as Jessica, because like this patient probably is gonna be vomiting and having like but I understand that you shouldn't also like give like prescribe, not prescribe, but like say to the patient you're not gonna eat anything also, because like and then I didn't think about it like that way, but thank you for the clarification.
Yeah, so in the hospital, we have to order a diet. And so, like, when I went into the hospital, I had to be put NPO because I was going to have surgery. So there's a reason for me to not have anything in my stomach, because they don't want me aspirating or anybody who's having surgery. Um, or if there's a risk of somebody choking, we don't want them eating. So there has to be a reason for them not having anything by mouth or having clear liquid. So if they're having upper GI or a lower GI, then they might be on clear liquids. But we want them to have access to food when they're feeling better, because that's going to help them get out of the hospital faster.
I think that point was pretty clear on yesterday's discussion, but the fact that was upon admission, and I think we mentioned about like after or as soon as the pain subsides, you want to start them in a full diet. So that upon admission was like, is she pointing towards the fact that the patient just got to the ER or to the hospital, so they are under like in pain. So that's why I didn't think about the full diet until that hint towards like pain subsiding.
Okay,
Like that's what
that's
it was.
reasonable. It is hard to add a bunch of nuance into Kahoot questions because we only have so many characters, but that's a reasonable thought process. Let's just the focus, the key part of this question is they need to eat as soon as possible. We should not restrict them from eating. Okay, so early refeeding decreases the risk of necrosis, it decreases the risk of organ failure, and it gets them out of the hospital. So it decreases the length of hospital stay. And we know that the less time we're in the hospital, the less risk we're for getting hospital acquired infections, right? Like Pseudomonas or MRSA, right? Okay, treatment for IBS-D in a 31-year-old male, status post gallbladder removal who has failed loperamide. Elcetron, rifaximin, aloxadoline, plecanatide. All right, so correct answer is rifaximin. Why did you choose rifaximin? Yes, Ernesto?
Because we want to control all delete the gut.
Oh, Control Alt Delete the gut. Yes. So the rifaximin is for IBS-D. Like I said yesterday, it's kind of Control Alt deleting the gut and resetting the bacteria in the gut to hopefully decrease the diarrhea. Rifaximin is approved in patients who are XX and XY, so patients assigned male at birth and patients assigned female at birth. All right. So why can't we use L-citron?
It's for female assigned at birth.
Yep, so it is for IBS-D, but it is only for patients who are assigned XY or female at birth. Why can't we use aloxadoline?
They don't have a gallbladder.
So what happens when you don't have a gallbladder and you use aloxadoline?
More complication.
What kind of complications?
Pancreatitis risk.
Yeah, pancreatitis. All right. So aloxadoline is contraindicated in patients who don't have a gallbladder. It is for IBS-D. It is for patients who are XX or XY. All right. And what about pulcanitide? Why can't we use pulcanitide?
IBS-C.
It's for IBS-C. So this is going to make this patient's diarrhea worse. You just harm the patient. All right, so the patient, pulling out the things we need, the patient is IBS-D, they're male, they have their gallbladder removed. That making the Control Alt Delete of rifaximin the only appropriate choice here. Right, what questions do you have on this question? I really think the IBS stuff is the hardest stuff. Even after teaching it for so long, it's still some of the hardest stuff for me to wrap my head around and remember the drugs and where they're used. So I wouldn't sleep on studying those. Which is a complication of chronic pancreatitis, constipation, weight loss, vomiting. So were you paying attention earlier? All right. Again, there's always one. There's always one. But the complication that is associated with chronic pancreatitis, there can be vomiting, but that would be an acute on chronic exacerbation. So that would be mostly due to the acute pancreatitis. Remember, patients with chronic pancreatitis get steatorrhea. That's that loosey-goosey, greasy stool because they're not absorbing any of their fat-soluble nutrition. And so if they're not absorbing it, it is coming out in their stools. And so if they are not absorbing any of their nutrients, they then get weight loss. Then it can lead to endocrine dysfunction, which is diabetes, which is the burnout stage. Okay, which bacteria is associated with peptic ulcer disease? Haemophilus influenza, Helicobacter pylori, E. coli, Pseudomonas aeruginosa. All right. Yes, H. pylori is the bacteria that is associated with peptic ulcer disease. Haemophilus influenza is associated. Does anybody know what Haemophilus influenza is associated with?
The flu?
No, the flu is a virus.
Pharyngitis.
I'm sorry, what was that, George? So it is upper respiratory typically.
I said pharyngitis, yeah.
Yeah, pharyngitis, upper respiratory. So influenza A and influenza B are flu. Haemophilus influenza is a gram-negative aerobic bacteria that is associated with upper respiratory infections. And maybe we all need to rewind a little bit and go back to. All right. Which of these increases risk for NSAID-induced ulcers? Rivaroxaban, nifedipine, atorvastatin, hydrochlorothiazide. Okay. So what type of drug is rivaroxaban? What's the DOAC? Anticoagulant. So anticoagulants increase the risk of NSAID-induced ulcers. So you need, I remember teaching you all this in the fall. So rivaroxaban, apixaban, dabigatran. You need to remember that those are anticoagulants, aspirin. Okay. Nifedipine, anybody know what nifedipine is? I think it should be a top 200, but I'm not 100% sure.
Calcium channel blocker.
Yeah, it's an dihydropyridine calcium channel blocker. So it really doesn't have anything to do with anything that we've talked about this block. Atorvastatin, what drug-induced disorder does atorvastatin cause potentially?
Liver.
It could cause liver. It's rare, but yes, we do hear a lot about statins causing liver disease. Ines, what were you saying?
For cholesterol?
Yeah, it is for cholesterol, but what drug-induced disorder do we talk about it causing?
Gallstones in the pancreas.
Yeah, drug-induced acute pancreatitis. So because it's preventing the absorption of cholesterol, that cholesterol has to go somewhere. And so that cholesterol is being excreted and forming gallstones. Gallstones then create pancreatitis. Okay, hydrochlorothiazide, what did we talk about that causing?
Drug-induced pancreatitis, acute pancreatitis.
Yeah, so it does cause drug-induced acute pancreatitis. How would we know that it might be due to the hydrochlorothiazide? How does hydrochlorothiazide cause acute pancreatitis?
Is it elevated triglyceride?
I don't think
Or
it
that's not.
increases the triglycerides, but it is metabolic. So you're in the right church, wrong pew.
Elevated calcium?
Yeah, hypercalcemia. So if the acute pancreatitis was due to the hydrochlorothiazide, we would see an elevated calcium on the patient's labs. Ooh. This is a big change. All right, which medication can help prevent NSAID-induced ulcers? Were you paying attention earlier? Metoclopramide, cimetidine, sucralfate, misoprostol. Oh, there was 6 that were not paying attention previously. All right, so metoclopramide, what is metoclopramide used for?
Diabetic gastroparesis.
Yeah, diabetes gastroparesis, which leads to nausea, sometimes vomiting. Cimetidine, we talked about being a H2RA. So It's not typically what we use if we're looking at that chart of how to prevent an NSAID-induced ulcer, H2RAs are not on that chart. They are not strong enough. Sucralfate is just for symptom management. So hopefully if a patient doesn't have a NSAID-induced ulcer, we don't need sucralfate. Sucralfate is just to help the patient eat, so cover that ulcer up, put that Band-Aid on that ulcer so they can eat. If you've ever seen it, it's like a chalky slurry. I don't even know how people drink it, or big chalky tablets. It looks absolutely disgusting to eat or drink. But knowing that it's like a chalky slurry will help you remember that it creates a coating and that it's not absorbed. I think that's one of the biggest benefits I had of working through pharmacy school, is like knowing these drugs and seeing them in real life and tying those connections there, right? So misoprostol, it helps protect the GI tract and is often combined with NSAIDs. So diclofenac comes paired with misoprostol, Arthotec. Remember, it's a abortifacient, so we can't use it in pregnant patients or patients who are trying to get pregnant. We talked about this drug in Women's Health earlier this week about how it's combined for medical abortion. So that is one of the risks with it. But misoprostol provides some of those protective factors for patients who are on NSAIDs.
Can we use PPIs for prevention as well?
Yes, we can use PPIs for prevention as well. And then we would also want to choose a COX-1 or COX-2 selective NSAID.
COX-2?
COX-2 selective, yes, because COX-1 is the pathway that is causing the decreased protective factors, right? So if we can pick something that's more COX-2 selective, which you should have learned, I think Dr. Mohammed taught you that in self-care. Right. Most appropriate treatment for a bleeding peptic ulcer. Famotidine IV twice a day, esomeprazole IV twice a day, pantoprazole IV bolus, omeprazole PO twice a day. All right, excellent. So why do we want to use that IV bolus?
To inhibit like very fast those those proton pumps.
Yes. So the IV bolus plus the continuous infusion is going to start working a lot faster than the oral. So it's going to bring that pH up faster, stabilize the bleeding to stop the bleeding, stabilize the clot, and promote healing. Because remember, an oral PPI takes 3 to 5 days to reach full effect. If we're giving a IV bolus and continuous infusion, that efficacy is going to start happening sooner. Okay, which medication can worsen IBS-C? Metformin, diphenhydramine, colchicine, omeprazole. Okay, what's the number one reason patients can't tolerate metformin?
Diarrhea.
Diarrhea?
Diarrhea. Okay, so what would that worsen, IBS-C or IBS-D?
D.
Yeah, IBS-D, yes. All right. Colchicine. What's the side effect with colchicine that you're to remember?
Diarrhea too.
Diarrhea. All right, so it's not going to worsen IBS-C. It's going to help it. Omeprazole can cause diarrhea if it causes C. diff and they're on it long term, but that's not what the question is asking. Diphenhydramine. What type of drug is diphenhydramine?
Antihistamine.
Anticoagulants.
So it's an it does have anticholinergic side effects, but what's its mechanism of action?
Histamine H1 antagonist.
Yeah, so it's a histamine H1 antagonist, crosses the blood-brain barrier, gives us those anticholinergic side effects. In your dreams, I want you to hear me say, can't see, can't pee, can't spit, can't. So it's not this, make sure that you're paying attention that it's not just diphenhydramine, but everything else that was on that same slide. So that is the dimenhydrinate, the hydroxyzine, the meclizine to some degree. All right. Doxylamine. All right, so that's a class effect.
What about the anticholinergics too?
Yes, so anticholinergics, yeah, the anticholinergics is a broad term for drugs that have anticholinergic side effects, because there's a lot of drugs that, like our TCAs are considered anticholinergic because they have but they don't work the same way that our H1 receptor antagonists work, right? So anticholinergics is a broad term to describe drugs that have a certain specific set of adverse drug reactions. When should antibiotics be considered for treatment of acute pancreatitis? Prophylactically at diagnosis, failure to improve after 7 days, or pancreatic necrosis develops. Right? We do not do antibiotics at diagnosis. A lot of times acute pancreatitis is not related to infection. Pancreatic necrosis is death of the tissue, not necessarily infection of the tissue. So necrosis does not indicate antibiotics. It's failure to improve after 7 days where we start antibiotics for patients. So we're giving them enough fluids. We're giving them medicine to control their symptoms, and they're not getting better after 7 days. We need to throw on an antibiotic. Okay, initial treatment for IBS-C in a 24-year-old female: lubiprostone, loperamide, L-Sutron. Right, lubiprostone is the correct choice. It is for IBS-C. All right. Loperamide is going to potentially make the IBS-C worse, right? Because loperamide treats diarrhea. So that's could cause constipation, make that worse. L-Sutron is for IBS-D. So again, that's something that could make the patient worse. Tenanepor is for IBS-C, but we don't really know its place in therapy right now. It's still relatively new. It hasn't been determined where we should use it. So that makes lubiprostone the most appropriate choice here. A little bit concerned about the 6 of you that chose loperamide. Right, so lubiprostone is for IBS-C for patients born XX. It's the second line, so that's after we use our over-the-counters to treat the IBS-C. Again, the tenanepor, we don't know the place in therapy, but it is for XX and XY, but that would not be the best choice because that would not be the next choice, right? Everybody understand? And then anybody who chose loperamide and L-Sutron is causing patient harm, because you're going to make the constipation worse.
I didn't understand the Tanapan or that you mentioned explanation.
You didn't understand what?
You mentioned about Tanapan, the unknown therapy, placing therapy. Like, what was that about? I missed it.
So we have our first line treatment for IBS is always the over-the-counter treatment that we can have, or the non-prescription. The second line, then we have second line agents, and then we have third line agents, and then Tananapur. We talked about that it's a newer agent. I think it was in 2019, and it's really not in the guidelines yet where it should go as far as second, third, or fourth line. So the best choice, Tananapur would not be wrong in this instant, but the best choice is lubiprostone because it is a second line agent.
Not racked yet. Oh, I see. Thank you.
What's that?
That is not racked yet. Like it's not placed. I see. Thank you.
So question, or so the drugs that you use for IBSD would cause constipation, and then the drug you use for constipation cause diarrhea. Is that how it goes?
Yes, that's correct.
Okay.
Okay, I have a request for a break, so we will take a 5-minute break. I have 12:41, so about 12:46, because we still have about 27 questions to go. All right, get your fingers ready. We will resume. Okay, true or false? Taking pancreolipase on an empty stomach improves efficacy. Ooh, all right. Anybody want to talk about what we use pancreolipase for and how we should take it?
Supplementation for digestive enzymes.
Yeah. So the exocrine function, when a patient has chronic pancreatitis, the exocrine function is the first function to go, and that is the absorption of nutrients from our diet. So if we don't have the proper enzymes to absorb our nutrients from our diet, we take those in the form of pancreolipase. And so we need to take those with every meal and every snack so that we can absorb the nutrients. So we should be taking pancreolipase with every meal or snack to help absorb that. Also, we might want to consider using an H2RA or a PPI to increase the efficacy so that the drug is not broken down in the stomach and it is allowed to get to the duodenum to do its work. All right, because all our nutrients are absorbed in our small intestine. So we need to make sure that this drug gets to the small intestines and is released there so that it can help absorb the food there. Best treatment for 44-year-old male with IBS-C who has failed fiber and laxatives: Tegaserod, lubiprostone, tanamipenor, rifaximin. Okay, so Tegaserod is for IBS-D. I did tell you did not need to know that one. I just couldn't come up with a good choice to update my question here. But it's for IBS-D. It's not on the market anymore from a financial decision from the company, not from a safety. All right. Lubiprostone. Anybody want to tell me what we talked about with lubiprostone?
For females.
For females, so patients who are assigned female at birth. So we can't use that. Tananipor is approved for people who are assigned male and female at birth. So this would be the best choice because it's for IBS-C. Rifaximin, we already used it to treat somebody with IBS-D earlier. So it's not going to help with IBS-C. Right. Which medication would you recommend for motion sickness? Diphenhydramine, loratadine, pyridoxine, famotidine. Right, diphenhydramine is the correct choice. So this is actually something that happened to me. My little sister got motion sickness a lot when she was less than 6 years old. And there is nothing on the market for kids for motion sickness, no medicine on the market. Because I think Dramamine is either 12 and up or the diphenhydramine is like 12 and up. And meclizine is also a higher age. So I had to use what I know about drugs, and I'm not super great at all, you know, the science part of it, but knowing that dimenhydrinate and diphenhydramine are closely related, I figured out how to use diphenhydramine for my sister's motion sickness so she wouldn't throw up on me in the car. She's 15 years younger than me, so I wasn't like a kid making these decisions. This is when I like picked her up. She was still in, yeah, anyways, so she's a lot younger than me. So knowing again how motion sickness happens and how the drugs need to get to where it happens or where it's being facilitated to treat, again, that diphenhydramine crosses that blood-brain barrier, helps with that. Loratadine does not. It's a newer antihistamine. Odinine is a H2 receptor antagonist, so that's for your acid reflux. And pyridoxine is B6 for which, where do we use B6? Pyridoxine?
Pregnancy.
Yeah, pregnant patients. Okay, what can be used to treat steatorrhea and chronic pancreatitis? Esomeprazole, pancreolipase, insulin, aloxidolene. So if you didn't know what steatorrhea is, now you know what steatorrhea is based on the picture. All right. So steatorrhea comes because we're not absorbing the nutrients from our food, our fat soluble vitamins. And so in order to help absorb those fat soluble vitamins and the fat, we need to use pancreolipase.
I remember a couple of years ago, there was a medication that people were pretty excited about, and then about like losing, and I think it was a pancreas lipase inhibitor, right? But then it didn't work. It didn't work well.
You mean for weight loss?
Yeah.
Yeah, so Orlistat is something you can buy over the counter, and Xenical is the prescription one, and you supposedly lose weight by decreasing the absorption of fat. But if you're not absorbing it, it has to come somewhere, so it comes out like that. So yeah, those people were walking around having greasy, oily, loose farts. So not really popular in the weight loss world. You can see why Ozempic and things like that have become more popular. Nobody wants to be around you when you have that going on. It's kind of like Shark Week, but instead of Shark Week. If you don't absorb something, it has to go somewhere. I mean, that is also how metformin works. Metformin, one of the mechanisms is that it prevents the absorption of sugar. So it has to go somewhere. It comes out as diarrhea, as Shark Week, not Shark Week.
Well, whatever it takes, right?
Yep. So I have to tell you the story. I used to, one of my jobs was faculty with a family medicine residency, and the first year residents were on rotation with me, and we were talking about drugs. There's also a diabetes drug called acarbose that prevents the absorption of sugar, and really you have explosive diarrhea, nobody wants to be around you. And so I'm telling the residents, and I say, this is an episode of Shark Week, and they're like, how do you spell that? And I'm like, SHART. And they're like, can you tell us what that means? And I'm like, oh my gosh, like, you are physicians and I have to explain to you what a chart is right now. Okay. So we had to like take a little detour on our topic discussion to explain what a chart was. Okay, which drug-induced pancreatitis will show up on imaging? Ceftriaxone, metronidazole, hydrochlorothiazide, conjugated estrogen. Oh, all right. So ceftriaxone, I want you to remember, we can't use ceftriaxone in little babies because little babies' livers don't work. It causes biliary sludging. The biliary sludging is dumping in to where the pancreas goes into that sphincter of Oddi, potentially gallstones. That is going, that is going to show up on ultrasound because it is blocking. There's something going on with the sphincter of Oddi. So anything that affects the sphincter of Oddi is going to show up on imaging. All right, metronidazole, we already talked about, is toxins. There's no way for us to show that. Hydrochlorothiazide, we talked about, as hypercalcemia. So it would be an elevated calcium on their labs. Conjugated estrogen increases your triglycerides. So you're going to see elevated triglycerides on patients' lab values. So things that show up on imaging would be statins, ceftriaxone, and then macrolides and NSAIDs, because macrolides and NSAIDs have a prokinetic effect that affect the functioning of the sphincter of Oddi, which would show up on the ultrasound. Which is the most likely to cause liver injury? Amiodarone, apretant, albumin, allosetron. Yes, very good, y'all. Amiodarone has a black box warning for liver failure, pulmonary fibrosis. It causes thyroid toxicity. It is the dirtiest of dirty drugs. There are drug interactions galore. There are major side effects with this. I actually identified before I left Maryland, I had a patient who had thyroiditis from amiodarone and pulmonary fibrosis from amiodarone. So also can cause liver injury. Okay, where should we put a scopolamine patch? Upper back, upper arm, behind the ear, abdominal. Right, yep, we're gonna put it behind the ear. Upper back, upper arm, abdomen are for our birth control patches. Behind the ear is for our scopolamine patches.
Dr. Ho?
Yeah.
Is it because like it's close to the cochlear cells and maybe that's why in the ear and that's why you put it in that, or is it because of other reasons?
I've never actually wondered or looked that up, so I'm not sure. I want maybe that's just where they studied that it's the best absorbed. I don't know. Does Dr. Hong, do you have any insight?
No, I maybe the proximity would be the reason. Yeah.
Thank you.
Yep. Where would you apply C-band for relief of motion sickness? Your forehead, your wrist, your ankle, your neck. If you put it around your neck, you're sure to not have motion sickness. Right, excellent. So the C-bands are the acupressure that go on the wrist, right on the inside of the wrist here. They look like those sweating to the oldies bands, and they have a little piece of plastic in them that put pressure on there. Okay, metoclopramide is best used for, were you paying attention earlier? Chemo-induced nausea and vomiting, general purpose nausea and vomiting, gastroparesis, postoperative nausea and vomiting. Right. Excellent. So metoclopramide is best for gastroparesis. Patients with uncontrolled diabetes have a tendency to have higher risk of gastroparesis. Patient admitted with acute pancreatitis is vomiting. Which medication do you use to treat vomiting? IV promethazine, IV ondansetron, oral promethazine, oral ondansetron. All right, we're not going to use IV promethazine unless we are diluting it. We cannot push that into the veins because it will cause extravasation, which is necrosis of the veins and the tissue around it. And so no bueno. We aren't going to want to choose an oral agent because the patient is actively throwing up. So we will use IV ondansetron. Oh, one thing about ondansetron, you'll see the ondansetron ODT tablets. That means on the tongue, not under the tongue. Okay. A lot of people think that because they are melting, you put them under the tongue, but ODT stands for on the tongue. Actually, I don't know if that's what it stands for, but you put them on your tongue, not underneath your tongue. What's that, Ernesto?
I think it's orally disintegrated tablets.
It's orally disintegrated tablet, but you put them on the tongue. I like mine better. All right, self-treating with Pepto-Bismol the last several days and needs testing for H. pylori this week. Which test is most appropriate? Breath, stool antigen, biopsy. All right, the correct answer is biopsy. So if a patient is on any kind of acid reducing agent, we cannot do the breath or stool antigen. We will get a false negative. So we need to do a biopsy. Well, not we. We're not going to do the biopsy, but somebody else needs to do the biopsy. But we do need to know which drugs interact with the test. So that would be true if they're on an H2RA. That would be true if they're on a PPI and Pepto-Bismol. They have to do a biopsy. Patient diagnosed with H. pylori, clarithromycin is 10%, resistance is 10%. What treatment do you recommend? TCA, tetracycline, metronidazole, bismuth, omeprazole, clarithromycin, amoxicillin, metronidazole, omeprazole, clarithromycin, amoxicillin, omeprazole. Okay, so you can really use any of these treatments, but because the clarithromycin resistance is less than 10%, what's the cutoff that we're worried about?
15%.
15%. But what is the best choice? The best choice is the 3 agents twice a day. Right? Wouldn't you rather take 3 agents twice a day versus 4 agents 3 to 4 times a day? So this is a kind of a best choice because they're all acceptable answers because nothing is ruled out by this case. But the best choice would be the one with 3 agents. There won't be a question like that on the test because there'll always be a clear answer. What do you recommend for initial treatment of morning sickness? Promethazine, pyridoxine, methylprednisolone, ondansetron. Now, this clearly says initial treatment. And there's nothing else in the case, right? I don't know why she's leaning with her hair falling in the toilet. Like, my hair is like in a bun when I'm praying to the porcelain gods. But anyways, So this is the initial treatment. Remember, the initial treatment is pyridoxine plus or minus doxylamine. It's that really expensive diclegis. That's our initial treatment. Unless there's something else going on. Yes, Ernesto.
That's for pregnant and not pregnant patients.
Yeah, this patient. This is for patient. This is for a pregnant patient. I think, didn't it say pregnant patient?
No, it says for, I don't know, in my end, what do you recommend for initial treatment of more morning sickness?
So sorry, morning sickness is what we call nausea and vomiting of pregnancy. So sorry. Yeah, people will say they have morning sickness because it typically happens in the morning. But remember, I said that morning sickness is a misnomer because it happens all throughout the day. So I will go and double check my exam question to make sure that that's clear. Thank you for pointing that out. Okay, which resource is best when determining likelihood of medication causing liver injury? Lexicomp, LiverTox, Google, Micromedics. Oops, Micromedics is spelled wrong. All right, excellent. LiverTox. Again, Micromedics and Lexicomp are basically the package insert in a database format, and those are not updated on a regular basis. LiverTox is it was last updated in December 2024. We'll see how much it is updated going forward, but. Patient presents with acute pancreatitis, triglycerides of 1,132. Which medication is responsible? Conjugated estrogen, atorvastatin, clarithromycin, Solenodac. Okay, conjugated estrogen can increase the triglycerides, so that would likely be the cause. Atorvastatin can cause gallstones, so that's going to show up on imaging. Solenodac is an NSAID that is going to cause dysfunction of the sphincter of Oddi, so that will show up on imaging, as well as clarithromycin has a prokinetic effect and will affect the sphincter of Oddi. So clarithromycin, Solenodac, and atorvastatin are all going to show up on imaging. There's not going to be any lab values associated with them. Conjugated estrogen can increase your triglycerides. Which is the best medication for treatment of abdominal pain in patients with IBS? Sertraline, lubiprostone, peppermint oil, Alisatron. Right, so sertraline is a SSRI, not typically recommended in IBS anymore. Usually TCAs or SNRIs are, so amitriptyline, duloxetine, venlafaxine might be recommended for abdominal pain. Usually we go with the antispasmodics, which are the one that starts with a H that I can't say without reading it. Hyask something. HYO, and then dicyclomine, and then peppermint oil. Peppermint oil is not prescription. It is an over-the-counter that is very recommended by GI doctors, so could be cost prohibitive for patients to get. Lubiprostone and Alisatron are for the diarrhea and constipation predominant, not the pain. Which medication can cause tardive dyskinesia? Loperamide, dronabinol, dexamethasone, metoclopramide. right? So metoclopramide, due to its action on dopamine, can cause tardive dyskinesia, which usually presents as the lip smacking that I was sampling for you. Which medication should be given for breakthrough vomiting? IV promethazine, PO promethazine, IV metoclopramide, PO metoclopramide. Right, so metoclopramide, again, mostly gastroparesis, maybe pregnancy. Promethazine is going to work even if the patient is actively vomiting. So we're going to use PO because IV is, again, causes extravasation. Epipetant is used for breakthrough nausea and vomiting, general purpose nausea and vomiting, gastroparesis, prevention of chemo-induced nausea and vomiting. Excellent. Our ants are used to prevent. This is the first time we've had a consensus, but we're also down to 9 people still participating. Okay, patient is receiving fluid resuscitation for acute pancreatitis and should be monitored with lipase, hemoglobin, urine output, weight. How do we know if they're getting enough fluid resuscitation? How do we know if they're getting enough lactated ringers? Right. So we're not going to measure serial lipases. That doesn't give us any information about whether the patient is getting better because lipase has a long half-life. So it's not going to adjust quickly. Hemoglobin would be more related to if a patient has a GI bleed and how much blood they're losing. Weight, maybe chronic pancreatitis is something we would monitor, or it is something we would monitor to make sure that they're getting enough pancreolipase. Urine output, because we want to make sure that they're peeing. If they're not peeing, then they're not getting enough fluid. Other things that we would monitor would be like their heart rate and their blood pressure to make sure that they're not getting septic and they're still be able to pump their blood and perfuse. Hematocrit can be an indication of dehydration, so we could also monitor hematocrit. But mostly we're going to be watching a patient's urine output and their heart rate to make sure that they're getting enough fluids. We're almost done. Which medication should be given at the end of surgery to prevent postoperative nausea and vomiting? Select all that apply. Ondansetron, promethazine, metoclopramide, fosaprepitant, methylprednisolone, meclizine. All right, so the correct answer is ondansetron plus a steroid. Oh, somebody said it didn't take more than one answer. You know what? I forgot to key it, so that's my fault. But ondansetron and methylprednisolone would be the correct answer here. Thanks for letting me know so I can fix that. But it is ondansetron plus a steroid that we give at the end of surgery. So when the patient is waking up, they do not have nausea and vomiting. Which medication is associated with anticholinergic side effects? Metoclopramide, promethazine, lubiprostone, This aprocitentan makes me think of the song Patat, that apartment song by Rosé and is it Bruno Mars? Patat. All right, promethazine, yes. Which medicine can worsen IBS-D symptoms? Amitriptyline, verapamil, colchicine, hydroxyzine. We've seen this question and talked about this various parts of this question in various forms several times. We should be at 100% here. All right. Yes, colchicine causes diarrhea. Hydroxyzine, what is hydroxyzine going to cause?
Constipation.
Yeah, so it is a H1/2 antagonist. It crosses the blood-brain barrier, going to have anticholinergic side effects. All right, which NSAID has the least risk of GI ulcer? Oh, diclofenac, naproxen, aspirin, ibuprofen. All right, so diclofenac is COX-2 selective, so it's going to have least risk of GI ulcer. All the rest of them are non-selective. Cold Winter Heart is making a comeback. I like that name. All right, so COX-2 selective NSAIDs include celecoxib, meloxicam, and then these three that we don't ever hardly see used. Nabutamoton, diclofenac, and etidolac. Patient with alcohol use disorder requires which medication? Pyridoxine, meclizine, thiamine, famotidine. This is the last question. Make it count, y'all. All right, thiamine. So thiamine is B1. Patients who have alcohol use disorder are at risk for Wernicke-Korsakoff, blah, blah. It causes mental status changes. So thiamine. So do not get your B vitamins mixed up. Pyridoxine is for pregnancy. P for pregnancy. Thiamine is the other one that I don't have a good thing to remember for liver. But remember P for pregnancy and you'll be good. All right, now you've seen every concept that could be on the exam. I gave you 10 extra questions than the 40 questions I'm allowed on the exam. So you've seen everything forward, backward, sideways, upside down, inside out. And the winner is IBS coming in 3. Lammy coming in 2nd. And Nesty coming in 1st. All right. What questions do you have over everything we went over?
Dr. Ho,
Yeah.
how did you suggest to tackle IBS and the different medications? Because I think that's the most, for me, it's the most difficult part because there's a lot of information and.
Yeah, so I think that I would probably if I were doing it, and I'm not great at studying, but I would probably make a chart like IBS-C, female, male and female, IBS-D, male and female, and which agents can be used. I think that would be how and then for pain, I would put all the drugs that are used for pain. So your antispasmodics and your TCAs and your SNRIs. I think I would try to fill out a chart like that. I think that would probably help you most, and then quiz yourself and recall on that. That would probably be most helpful with me, or creating flashcards with that. But if you can organize them, and then maybe you could come up with some kind of mnemonic when you put the drugs in there, like IBS-C females are these letters. What silly thing can I make up with these letters? IBS-C for male and female are these letters. So try to come up with your own mnemonic for those. I think that could be very helpful. But I wouldn't study them just on the slides. I would organize them all on one page so you can see everything at once and how they play together.
Thank you. And I have a question for Dr. Hong. So I was like, for this structure, I was a little bit like confused because it has like a similar structure, but how can I like say this is an antagonist or an agonist if they have like a very similar structure?
I'm not going to trick it like that. So that's a little, deeper medicinal chemistry. Usually, I wouldn't say all the time, but a lot of the time, the transmitter antagonists have retained the core structure of the natural neurotransmitter, but usually, it's a little bit bulkier compared to it. And versus agonists, usually they fit in a little bit better. But I am not testing that type of thing. The Kahoot was just to variations of it, of how, to tell you to be able to recognize some of those core structure. Yeah. I'm not gonna give you like two molecule have the same core structure and then ask you which one is antagonist or agonist. That's beyond the scope of our what is needed to know. Yeah.
Thank you.
Mm-hmm.
What other questions, concerns you have?
I have a question for one of your abbreviation that I saw in pancreatitis. It was CI. It's for contraindicated or?
Yeah, CI means contraindication.
Thank you.
Okay, I have a question in the chat about transgender patients. And so, and maybe I didn't do a good job at explaining this, or maybe it's just a tricky concept. So when we say transgender male, that person was, their sex assigned at birth was female, and they are transgender male. So they want to live their life as a male, but they were assigned female at birth. If we say transgender female, that means they were their sex assigned to birth was male, and they are presenting and living their life as a female. All right. So make sure you pay attention to that slide, that last slide of the IBS that explains that a transgender male their chromosomes would, again, oversimplifying it because chromosomes are a lot more complicated than just XY and XX, but a transgender male chromosomes would be XX. A transgender female's chromosomes would be XY. So review that question that you had on the case and review that slide. If you have any more questions, if that doesn't clear it up, please let me know in the chat privately or send me an email and I can send a further exclamation or explanation. All right, I hope you all have, I won't keep you, we're out of time, I think anyways, we're over time. But thank you for your participation today.